A very warm welcome to you all. This is our first lecture of the Knowledge with Impact series this academic year. So my name is Helen. I'm Assistant Dean for Research in the Faculty of Education and Health Sciences. So really delighted to be here today, and thank you particularly to our presenters. So particular thanks to our speakers, so Professor Karen McCreesh, who's here beside me, and colleagues from the School of Allied Health, so Professor Kieran O'Sullivan, Dr. Helen O'Leary, Dr. Clodagh Toomey, all from the School of Allied Health, and also to their partners, Chronic Pain Ireland, the Kerry Knee Group, LSP, and the Musculoskeletal Disorders Research Group. So we really value these partnerships, and we're delighted that some members of those partners are here with us today. So particular thanks to Martina Phelan, who is joining us from Chronic Pain Ireland, who will present with Professor McCreesh today. I'm also delighted to welcome Lauren Guilfoyle, who is a PhD candidate in the Physical Education and Health Sciences Department, or PES as we more commonly refer to it. And we're really delighted to have you here, Lauren. It's really lovely to hear from people at all stages of the research journey and at all stages of their research careers. So thank you, and a very warm welcome to you. We're also delighted to have our heads of school, Professor Pettigrew, School of Allied Health, and also we have Professor Perry, who's here from PES today. We're delighted to have you both joining us, and a warm welcome to you both. Our Dean extends her apologies for not being here today. She had a prior commitment, but she'll look forward to the recording in due course. So this lecture series wouldn't have happened without Sinead Liston, who is here with us today. Sinead is an amazing power of organisational skills, so thank you for all your help with organising today's event. And thank you also to Emmett for recording today's lecture. Okay, so I'm going to hand over to Professor McCreesh, and the title of this talk today is Navigating Pain, Co-Creating Better Musculoskeletal Care. Thank you.
Thanks very much, Elaine, and just to reiterate those thanks to Martina for being with me here. I'm going to hand over to Martina towards the end of my session to talk a little bit more about the partnerships that we have. So the title of the talk is about navigating pain and co-creating better care for patients with musculoskeletal disorders. So here we're talking about aches and pains of the bones, joints, limbs, soft tissues, the bread and butter of us musculoskeletal physiotherapists, but also, conditions that people live with that have an enormous impact on their lives. The reason we've kind of put the talk together this way is partly based on an award that we won last year here in the EHS faculty. So it was the Research Recognition Awards from 2023, and we were awarded in the category of public engagement and outreach. And as part of applying for that award, we kind of sat down, a number of us, and really talked about the kind of things that we do and the types of impacts that they have, not just for our own research, but then for the wider landscape of musculoskeletal care. And so I want to kind of express some of that work that we discussed then, and that's what we're going to talk about today. So I'm speaking on behalf of Professor Sullivan, my colleague, Clodagh and Helen, who are postdoctoral researchers within the school, and a range of PPI contributors and research partners that are all part of what we do. I want to have a brief talk about the kind of knowledge gaps and problems that we work on. I'm going to give just a peppering of project examples. So just going to talk about 3 different projects in a short period of time we have today to illustrate some of those problems and the impacts of the work that we do there. And I guess the key element that I want to focus on is the co-design. So, traditional research design and conduct's really quite linear. That's certainly how I was trained as an undergrad. Research follows in this straight line from the project that you designed, to the project that you conduct, to those outputs that you took out the other end. And often there wasn't much of a recycling of learning that happens within that project, and certainly there wasn't a huge amount of input from the people that would gain or benefit from the research that you're doing. We're all in a very different space with our research these days, and I'm pleased to say our research is no different, is that co-design is very much at the heart of what we do. And on the left, I'm illustrating here really what I see as the benefits of co-design that are not just happening in the design of your project or the getting the funding, ticking that box. Because there's temptation that, okay, well, all the funders now say we need to do co-design. So let's make sure we have it in this initial part of our research. But I think, I'd like to emphasize that the key roles really, really only ramp up when you're in the middle of the project, when you're in that messy, arms deep in the project itself. there's where your stakeholders and your co-designers are going to be of huge support. Sometimes saying, I told you so, and you didn't really listen. But all of that's so valuable. And then as we move into the outputs, again, how to communicate those outputs to the communities that really can benefit from them, but also then the wheel of how that output comes back into the design of the next piece of research. And so that's what we're aspiring to with the work that we're doing as musculoskeletal researchers. And again, as I said, I'll illustrate some examples of that today. This is one of my kind of favorites in terms of helping, me and the people I work with understand what we're trying to do here, which is, Maggie's in the baby seat and she's got the steering wheel, and she really believes to some degree that she's driving the car. But we all are in no doubt that Marge is driving the car and that Marge is taking us where we want to go. And we want to make sure that that's not what we're doing with our stakeholders as researchers, is that putting them in the driving seat very meaningfully, and not sort of pulling the wool over somebody's eyes of, we're listening, but we're still going where I want to drive the car. And again, that's the philosophy for me. I hope to build and aspire through the work I'm talking about here. A really insightful paper for me, and something that kind of really made me think a lot, was this paper I read last year on kind of reflections on patient engagement and how it can go wrong. And I think for me, I'll just highlight the last column here. But things we're trying to avoid, the tick box approach, any kind of unconscious bias towards your partners, not fully including people in a way that they can do so meaningfully, and not recognizing the vulnerability of the people that you're working with. And so these are the sort of questions I try to ask myself. Am I really accepting feedback and integrating it into the work? Am I asking really thoughtful questions about people's lived experiences, rather than the questions I might have about my own research gaps? How can I make this space meaningful and inclusive, and particularly in musculoskeletal pain? That can actually mean the physical space as much as the emotional and psychological space that we create for our partners. And then how can we share that power and privilege in a way that balances the responsibility in a safe way, so not handing responsibility to people where they're not either compensated or trained or supported for that, but can actually give that power and privilege across, again, in a way that's really done like a true partnership. The first project I want to use as an example is the work of Dr. Helen O'Leary. Helen's a clinical specialist physiotherapist in Tralee. Helen did her master's with us many years ago here in Allied Health. She went off and did her PhD elsewhere, and then we coaxed her back for a postdoctoral award with the HRB. And Helen's work centres around a particular type of knee pain. It's a degenerative, so wear and tear kind of knee pain that we get in middle age. So somewhere between 45 and 65, what you might know as cartilage tears, because that's what the world knows them as, okay? We look at them very differently as musculoskeletal physiotherapists. So we talk about early degenerative changes of the knee. And to give you an example of what the experience of somebody with this condition is like. So they get a sore knee, they go to their GP. They've heard from lots of people about knee cartilage is something that you usually need surgery for. So at some point I know I'm going to have to do that. And I'm definitely going to need a scan because I need to know exactly what it looks like on the inside. So they have a consultation with their GP, and really the right place for them for care is to go and have physiotherapy with their primary care physiotherapist. And that alone is the most effective means of managing this condition for a long period of time. Most of these people actually rarely end up needing surgery. But what happens in Kerry, in the example we have here, is that there's a hugely long delay to get access to primary care physiotherapy. So that pathway of care is tending to drive a lot of things that shouldn't happen in a GP consultation for a grumbly knee when you're 50 years of age, which is people are being sent for a scan. People are being sent forward into the secondary care clinics. So they're being referred to the orthopaedic consultant because the GP is saying, well, I might as well put it in there just in case because they're going to need it at some point anyway, aren't they? And this really has tended to lead to huge escalation of care. So there's a large number of people sitting in a secondary care waiting list in Kerry Hospital in Tralee, the University Hospital in Tralee, who also are not going to be seen by the orthopaedic surgeon because they're not a priority for surgery. They're not an emergency group of people that need to be seen quickly. So people are sort of in this place of sitting on a waiting list for physio, sitting on a waiting list for the orthopaedic surgeon, and nobody ever really getting to see them. They may get to see what's called the musculoskeletal triage physiotherapist in secondary care, but that person will absolutely be sure to send them back onto the primary care waiting list because that's where they belong. So the experience of the people with this condition are really what we're looking at in the Kerry Knee Group. So this is a group that Helen has founded, a group of people who've experienced this type of knee pain in Kerry. We got some funding from the PPI Ignite in UL to support this work, so again, we really, really appreciate that. So the kind of conversations we had with this group were founded around the idea of what do these stakeholders want from a clinical consultation for knee pain in the current system. Okay, we can make utopia as all we like, but what can we do in the system that we have now that will support a better pathway of care? And we asked them things like, what does a good clinical encounter look like? What do people with a new episode of knee pain want to know? And how can we make current care better? And Helen has a raft of publications of qualitative work in advance of this as well. But this was very much more a communication, a conversation. This wasn't a piece of research. And it was very clear that people wanted a really clear diagnosis and treatment plan and an understanding of what that pathway of care would be and why. Why am I not having a scan? Why am I not having surgery? Why is physiotherapy the right place for me to be? Maybe if that's the case, could I self-manage myself? Because I'm working and I'm busy and I don't have time to go to physio appointments. So this idea that they wanted information on simple exercises they could start with, that they could be signposted to different resources, and that the fact that the recovery was really in their own hands needed to be spelled out to them. So this piece of consultation that we had with the Kerry Knee group led to the Knee Deep, the Knowledge Translation and Exercise for Early Degenerative Knee Pain project. And in fact, Helen was on the phone this morning. I think we're on our second last participant to recruit for this project. So we're hoping to have it fully recruited by Christmas, which is really exciting. So this project is funded by the Health Research Board. It's a part-time 0.5 postdoc over 5 years, which is a lovely embedded way to deliver research and clinical practice. Helen continues to spend half her week in her clinical specialist role. We've created what's called the Enhanced GP Consultation, and we've done that through GP training and workshops where the GPs are really empowered to give the right messages in the 7-8 minutes that they have with patients. So what are the clear messages that you need to give across to these patients? What's the clinical examination you need to do as a GP to be sure that you're confident this is the right pathway of care? We've given a number of resources, so patient advice leaflets and a management plan. But that on its own was never going to be enough. So one of the key elements of having the stakeholders in Kerry Physiotherapy and the orthopaedic clinic were we've adapted the pathway here. So what's happening now is that the GPs are willing to give this enhanced consultation to patients. They're being given access to physiotherapy within 2 weeks. Okay, so within 2 weeks, the patients are going to be seen in a one-off consultation with the physiotherapists. That's a 45-minute session with an experienced physio who really goes through education, self-management, again, reassures the patient, I've seen your knee, it's early, wear and tear changes, this is not something that needs to be ameliorated with surgery, and it's highly likely it's going to recover with this type of care. Then people pop back onto whatever waiting list is appropriate for them, which might be primary care physio. In none of these cases is secondary care the right place for them. However, if at any point in this, on the left-hand side of the line, either the physio or the GP feels like they do need to be escalated to secondary care, we also have agreements with the secondary care consultant that I will take them knowing that the person has engaged in their evidence-based care already and they really are on the right pathway when you send them to me. Okay, so these are all negotiated agreements so that we get that timely access for the patient to be where they need to be at any point in time. This is a feasibility study. We're looking at sort of 45 patients going through this pathway at the moment. And again, really important to see where, where it goes in terms of clearly patient outcomes. But I guess the key thing we're interested in is when do they cycle back into the system? So we're going to follow them for a full year after this to see, okay, where do we see these people again? Or do we actually end up needing to seeing them again? The other part of this I want to emphasise is the experience of the Kerry Knee group. And this is Matthew Hopper, who's kind of the lead PPI representative within that group. Matthew presented at the PPI Ignite a couple of weeks ago absolutely beautifully. And this is one of the parts of the slides that he used in that, so he's given me my permission to include it here today. And what we asked Matthew was, what was your experience of being part of this Kerry Knee group? And did we live up to what you expected? And I suppose the key things he said was that his experiences and those of the other patients were definitely incorporated into the design of the research, that he felt we did go looking for a diverse group of patients because people have had all kinds of pathways. So within the knee group, we've had people who've had surgery, people who haven't had surgery, people who are early or who are late in their journey. And that, he felt they were treated as equal and ongoing partners in the research team. But one of the most interesting things that Matthew told us about that experience was actually that what he called the happy serendipity of being in this group, which he felt was kind of almost nothing to do with what you and Helen were at. It was what we were doing as a group together. And here are the things. He said, within our group, we provided and received empathetic peer support. It was an opportunity to practice self-compassion. Like, I had this really bad experience through this pathway. So did I. So did you. And the fact that I'm still struggling with my knee pain two years later might actually be because of that, not because something I've done wrong. This idea that, being part of a PPI group helped him develop increased autonomy, because through these discussions, they developed a better understanding of both healthcare pathways and of research. So again, I suppose this is what we want to keep looking at, is this open feedback loop of, are we actually delivering those kind of values that we want to in terms of engaging with our stakeholders. I'm going to move on to talk about the broader area of chronic pain. And this is just really an example. Sometimes I use with students. This isn't a real person. This is a stock photo. But, the kind of things that we help, our audiences understand about chronic pain. So Margaret would be an example. 1 in 3 older Irish adults, so over 55, has persistent pain. This person has fibromyalgia, knee arthritis, spinal pain, good days and bad days, but pain impacts every day of her life. She complains of fragmented sleep, poor mobility, and often becomes isolated because of being unable to make social engagements reliably. Her pain is a knock-on effect on other health issues, so it makes it difficult to exercise or to have a healthy diet. And typically, people with chronic pain have bad experiences with healthcare providers. So our next project is really focused on the experiences of our next 2 projects on the experiences of people with chronic pain. A brief discussion about this one, but just showing you that this can happen at all levels. Abby's a PhD student within the School of Allied Health, supervised by Kieran. And again, Martina is a key part of this project from Chronic Pain Ireland. But Chronic Pain Ireland would have identified that poor sleep is a really key concern of their members. And this project was a PhD project that was framed around that, where Abby completed a scoping review of interventions for sleep dysfunction, then developed a series of World Cafe events with people who live with pain, but also with clinicians who support people with pain, to look at what are the barriers to providing services to support better sleep in people with chronic pain. And that project has developed into a co-design of a blended cognitive behavioural training programme, again, to improve sleep quality for people with chronic pain. And it got funded by a big European group called the BMP, and Martina, again, can highlight that. So that's an example of a real-life problem that came from a stakeholder, and again was embedded in a relatively small-scale PhD project. This one's a much bigger scale. So since 2019, Martina and I have been working together, initially funded by the IRC New Foundations grant, so it's just a little sprinkle of money, but can do a lot, on this idea of how do we support people with chronic pain to exercise, to engage in physical activity. And so it's been an ongoing project where we started with, what do we know about community-based exercise, and that was a systematic review. Lots of work to identify the needs of people with chronic pain, and then it became obvious, well, actually, we need to talk to the providers of exercise. So Limerick Sports Partnership are the group we're talking about. And when you're a trainer running a class, what are your needs in terms of understanding the needs of people with pain? And it finally culminated then in 2023 of us designing a community-based programme and securing funding from the HRB DIFA Awards. When we talk to both the trainers and the people from Chronic Pain Ireland and our lived experience people with pain, while there were things that were different about their needs, there were lots and lots of overlap. So people with pain talked a lot about, I need someone I can trust. I need someone who's going to have empathy if I'm going to join them in a class. I need someone who's going to foster peer support. I'm going to be really inclusive of my needs. The trainers were saying, we want to be inclusive, but we don't know how to do that for people with pain. And we need training. But the things that were common were everybody was fearful about pain. Everyone was fearful about, are we going to make things worse? Both the trainers and the people with pain had that same fear. Had that fear about, can we adopt exercise? Had that fear about, how do we make it fun and about participation rather than being competitive and about milestones? So, once you put that together, it was clear that, a project that met all of these needs wouldn't be that hard to find. Because again, there was so much shared values and needs there. So this is the Connex Pain project, which is running at the moment. These are the manuals actually that go out with that, just even if you want to have a wee look at the kind of things that we've produced with our stakeholders. So there's 2 main arms to it. It's called the Train the Trainer on the top here. So we train the community exercise trainers. And Kieran is the lead of that work package, and you can imagine they get a great package of training in terms of understanding pain. We work with the trainers to adapt the existing classes to the needs of people with pain, and that includes dropping the instructor ratios, looking at the venues, doing various things that make those classes more accessible, more inclusive, And then we really do want to focus on the experience of the trainers in this new way of kind of delivering exercise for them. Our second work package is about working with people with chronic pain, recruiting them to take part in community-based exercise classes, and again, looking at the experiences that they have of doing that. And our group of patient partners, this is actually our older adult group, but again, some of these are still part of our chronic pain study, do so many different things for us. They help us develop these materials. They give us huge advice about how to recruit people into the study. They are members of our trial management committee. They're members of the trial steering group. And again, as we move forward, they're going to help us interpret our data and develop some of the dissemination materials. And again, like having Martina with us today, help to give presentations to those who are interested in what we're doing. This is the study. The protocol is published in HRB Open, if anyone wants to have a further look. But essentially, as I said, we have our strand, which is all about training the trainers. That's really sustainable. That training doesn't go away. So even though this is only a feasibility study and we've trained 5 trainers, that rolls forward, and we hope to make that something that we can roll out on a wider basis. And we're very much knee-deep in strand 2 at the moment. We have half of our participants recruited for our feasibility study. So we've got Pilates classes running in Lord Edward Street. We've got aqua classes running in St. Gabriel's. So this is ongoing. So I'm presenting something that doesn't have outputs, but what I do want to talk about is the kind of things that are happening in this muddy phase of being knee-deep and doing it. And these are the sort of things that are going on. We've an ongoing process evaluation, which strongly includes all of the stakeholders. So the trainers, we're talking to them all the way along, so they're constantly kind of having mini interviews with us at the classes, on the way out of the classes, doing calls with us in between the classes to build this understanding of what's going on. And they're telling us things like, we see the vulnerability, we see people opening up about pain, and that's a real revelation for us. We didn't expect to see that. They're telling us about how they're adapting the classes on the fly. They're saying, I just noticed that people could really benefit from having an exercise sheet when they leave the class. I'm happy to design that. Shall we do that together? And equally, our participants are understandably saying, class is great, but what happens next? Where do I go now? They're developing peer groups, of course, outside of the class. They're asking, but all the classes are in Limerick City, and I've got this friend out in Kilmallock who'd love to be doing this too. And they're giving us more suggestions about venues that can be accessible and inclusive that are not ones we're using at the moment. So that ongoing co-design is something, thankfully, in a feasibility study we can foster and we can really listen to. And I guess I'm interested in continuing that and hoping that that becomes something that really informs any future trial that we might do. I'm going to pass over to Martina now. Trying not to hog all the time. And again, Martina is the chair of Chronic Pain Ireland and has been an integral part of, in this case, the sleep project and the community exercise project with us.
Thanks, everybody. I'm delighted to be here speaking to you today on behalf of Chronic Pain Ireland and on behalf of everybody with lived experience that's been engaged in research in UL and everywhere else. So just a little bit about Chronic Pain Ireland. We were established in 1992 by a pain specialist and a group of patients who saw the need for an organisation to advocate for the cause. Today we still advocate and we work very closely with all our stakeholders, now including several universities where we have PPI, public patient involvement or engagement, if you want, in research projects. So just a little bit about me. I'm going to tell you my story today because I think it's fairly relevant and because I believe that through this type of patient engagement we get personal empowerment. And for me, I've lived with chronic illness for over 40 years, chronic pain specifically, and that's tested my strength, my resilience, and my advocacy. My pain has shaped me into the passionate advocate that I have become for others that are facing similar challenges. In 2017, I joined CPI in order to give back to people that had advocated for me and worked for me for years. In 2020, I took on the role of chairperson, and since then, I have served as the CPI representative and spokesperson to ensure that the voices of those living with chronic pain are heard at both national and international levels. I'm also the patient representative with the Faculty of Pain Management, so I work closely with healthcare professionals to improve pain management practices in Ireland. Something I know is vitally important both to pain professionals and patients. I've also been fortunate enough to engage in national and EU campaigns involving and research initiatives, including here in UL, the CBTI World Cafe, the COMEX Pain Initiative. In UCC, I was involved in the ESPIDA project from the beginning. So while my journey has been a huge challenge, it's also been one of massive empowerment for me. Through patient engagement, I found a way to transform my pain into advocacy that helps others navigate their own journeys. It encouraged me to return to third level education, and it has also guided me towards going into research myself. So I am an undergraduate here in UL at the same time as I'm doing all of this, and my plan is to do sociological research into chronic pain. That's my long-term view. In Chronic Pain Ireland, we actively encourage all our members to take part in all the varied PPI initiatives, and we provide opportunities through all the research partnerships and collaborations that we have. All of our supports and services aim to empower our members on their own personal journeys. The impact on the patient through engagement in research. The feedback that we've had is that they feel their voices are heard. They feel that their engagement has been valuable. They feel useful to society, because too often people with chronic pain are isolated and they feel like they're a burden on society and on those around them. It improves their confidence, not just on the project. I can say that when I started, I felt like, what am I doing here? I have no idea what I'm talking about. But in truth, everything I said was hugely valuable into shaping all the research that went on. And here I am today. Others are taking my place through the same journey. It also improves their confidence in dealing with their healthcare professionals. They can use the knowledge that they've gained on the research in their everyday lives. So for instance, on the COMEX Pain and the CBTI Cafe, they're learning ways to do exercise that, while they may feel their pain increases initially, there are massive health benefits afterwards. They know that the pain is not a danger to them, whereas before they would have believed all pain is a danger. You have no idea how massive that is to somebody with chronic pain. Ultimately, engagement in research projects and the outcomes of the research projects, for instance, the CBTI helping people to learn strategies to sleep, leads to a massive improvement in mental well-being. The impact then for CPI as an organisation for Chronic Pain Ireland. It raises the profile of the organisation to have partnerships with the various universities and be engaged in various research projects. It raises the profile of the organisation in terms of applying for funding. But it also, and more importantly, helps to add services to the organisation's profile. So we would hope that the outcome for the COMEX Pain in the long run is that we can say to all our members, and say confidently, this class being run by Limerick Sports Partnership is safe. The trainers have been trained. They can accommodate you. Please take part. We can say for the CBTI World Cafe, this is a programme that's been developed. We're going to run it. For the ESPIDA programme we ran in UCC, is to develop a workshop to help people deal with the stigma of pain. We hope to roll that out in the next few years. All massive benefits to the organisation and to patients themselves. Impact on the research. Patients and researchers often view the same subject from very different perspectives. This is a good thing. It can steer your project towards more patient-relevant outcomes. So traditionally, research and healthcare systems, they've struggled to fully address the challenges faced by those with chronic pain. Through patient engagement, patients' lived experience can guide the researchers and clinicians to help shape the research questions and the healthcare innovations so that they're grounded in the real-world needs of patients rather than just theory. This connection fosters a deeper level of understanding and empathy, bridging the gap between complex research language and patient experiences, enabling the design of solutions that not only improve pain management, but also mental well-being. People talk to their friends, their families, their peers. This helps spread the word about the amazing work being done in UL and other universities. They tell them how they've been included, how their voices have been heard, they've been listened to, their ideas put into practice. When they speak to their peers about the research, they're spreading the word that this research is being done. And this is only a benefit for all projects out there. To have the word spread not just among the academics and the healthcare professionals, but to have it on the ground. So, that is me. Very short.